Good afternoon. My name is Joni Paris. I'm one of the WOCN advanced practice nurses in the Cleveland Clinic Center for Connected Care Mobile Wound group. And so today I've been asked to talk to you just a little bit about basic wound care and wound instruction. So I have identified three objectives for today. We are going to cover some information so that the learner will be able to list the steps for basic wound assessment. You'll be able to demonstrate wound measurement technique, and then lastly the learner will be able to list 3 types of wound treatments. So one of the things I always like to start with is where to begin. So one of the first things, weirdly enough, is when you take the dressing off of the wound, you want to assess the drainage on the old dressing. You want to assess the odor and color of the drainage. You want to assess the amount of the drainage, assess the wound tissue, and assess the surrounding tissue. Is the dressing saturated? Is the dressing dry? What type of dressing is on the wound? Does it come off easily, or did it cause trauma to the surrounding tissue when you took it off? I mentioned odor a few moments ago. For odor, you want to clean the wound first, then assess. I get multiple calls from people telling me that wounds are infected because they smell. When they've been dressed, particularly in the home care setting, we typically only change them 2 to 3 times a week, so that dressing's been in place for a few days. It is going to smell when you first take it off. So the key is to first of all clean it with either normal saline or a mild soap and water, rinse it, and then pat it dry, and then decide if it has an odor or not. When you do notice an odor, then you want to give some descriptive words. Foul, musty, fecal, sweet, strong, those are some of the ones that come to mind for me. The type of dressing can also affect the odor, and first and foremost is calcium alginate, which we're particularly fond of in the home care setting because it lends itself to that 2 to 3 times of dressing change per week. So for calcium alginate, remember that it is a medical grade seaweed-based product. It may have a fishy odor. The other thing that it often does is turn the drainage green because again, it's made from seaweed. So if you see green drainage or a fishy odor and the calcium alginate is the product that's on it, discount that then. That's probably not odor from the wound. It's more likely odor from the dressing. Some of the other things that we want to do in looking and assessing a wound is color. So you'll have a variety of them: red, yellow, green, tan. You can have clear, you can have white. I already mentioned that an alginate may produce a green drainage. There is another thing that will produce a green drainage, and that is Pseudomonas. Typically though, it's a very characteristic odor, and once you smell it, you'll always remember it. You'll probably have to eat a mint afterwards because it'll still be in your nose. Even when you leave, you'll still think you smell it. It's a funny, almost a combination chemical, musty, sweet sort of odor. But the drainage is more of a blue-green. So the calcium alginate will give you more just of a green tinge. But if you have Pseudomonas, it's often more of a blue-green. And as I mentioned, if you clean the wound, you're still going to have the odor if it's Pseudomonas. So that's just some of the way that color plays into assessing a wound. One of the other things we want to look at is amount. And what I did was try to put some percentages on it to kind of give you a guideline. If you are calling it a small amount of drainage, you're talking about 25%. So if you're looking at the old dressing, for instance, it'll be about 25% contaminated with drainage. If you are moderate drainage, it'll be 26 to 75% of the dressing, and for large, it's going to be 75%. I'm also fond of the word copious. If you have one that when you take it off and you're picking it up and it's dripping and it's saturated from edge to edge and there isn't a dry spot on it, that's probably copious drainage. And the key there is we probably need to do a better job of picking a dressing that is going to better control that drainage. Because wounds heal by moist, by being moist. That's basically what our bodies are made of. They're mostly water, and so moist wound healing is the way to go. However, I tell people it's the Goldilocks principle. You want just right. You don't want too little, you don't want too much moisture, you want just right. And so if you have a dressing that is dripping wet when you take it off, we're probably not just right, and we probably need to do a little better job with that. You can also look at the consistency of the drainage. You know, it could be stringy, curd-like, thick, thin. People are fond of the word purulent, and I'll bring in right now and talk a little bit about slough, which is that yellow thin layer that you'll see on wounds sometimes. That's devitalized or dead tissue. And so when slough liquefies, that's how it removes itself from the wound, it becomes like a liquid. It will often leave a creamy or a thick or an almost purulent looking type drainage on the dressing. So again, I urge you to clean it first and then decide, maybe see if it puts out additional drainage while you're looking at it, and then make a decision as to whether or not it's actually purulent drainage or is it simply liquefying slough that it's putting out. Now, one of the other things we want to do is pay attention to the wound tissue and the surrounding tissue. So you want some words that we're fond of in the wound world for using to describe wound tissue is beefy red. You know what, Sharon, that might be a good time to show them the partial thickness and full thickness slides, just because that's a pretty good indication. The one on my left is the partial thickness one that's beefy red. You can see it spans over two buttocks. So that is the kind of tissue that we want. That's actually, believe it or not, good healthy wound tissue. It's beefy red, it's moist, that's healthy tissue. The one on the right here is an example of a blister, and often people think that blisters are sort of innocuous and not really important, but the truth is that blisters are actually already a break in the skin integrity, because occasionally they will absorb back into themselves and you won't have a break in the skin, but more often than not that blister is going to open up. And if you've ever worn a pair of shoes that rubbed a blister on your heel, you know what I'm talking about. You try to protect it, you pat it, you know, but in the end it opens up and you've got that sore underneath. So that's what we're showing you there. Those are examples of partial thickness, but that one on the left actually shows you what nice beefy red tissue looks like. We can also talk about yellow and black tissue. And the yellow I mentioned already when I talked a little bit about slough. So what happens is that's just dead devitalized tissue. It's usually thin, but it can also be what I call thick and adhering to the wound base. When it's thick and adhering, it often also takes on kind of a tan color. And slough will smell even after cleaning because, again, it is dead tissue. The black tissue is what we call eschar, and that typically does not have an odor as long as it's intact and kind of leathery looking, because it's sort of covering the wound and encasing it so that you don't get the odor. But once that starts to open up or detach from the wound edges, then you'll usually have a pretty significant odor. But again, not necessarily infected, it's really simply because in both of those cases that is dead or devitalized tissue, and so it is going to have an odor. Now, we talked about paying attention to the surrounding tissue also. We call that the peri-wound. And so you want to look for things like, is it indurated, which is a fancy word for hard? Is it erythematous, which is a fancy word for red? And when we talk about wound infection, if it's red, but you put your hand on it and it's not warmer than the surrounding tissue or warmer than any of their normal intact tissue, then it is probably not infected. Usually you'll have a temperature change also if the red indicates that it's infected. If it has a jagged edge to it, or you saw it one day and it was a centimeter or two up from the edge of the wound, and now it's traveled up another couple of centimeters. If it's traveling, then it's more likely that it could be an infectious process. We talk about boggy. That's kind of a fancy word for spongy. When you press on the tissue, it feels like there's probably either something soft underneath it or it feels like there's fluid underneath it. Then the last thing is macerated tissue, and that's a fancy word for soft and white. And probably the best thing that all of us have experienced at one time or another is if you washed a lot of dishes or you soaked in a tub, you look at your fingertips on the backside and they are sort of that white pruned look. That's macerated tissue. And that's important because macerated tissue is now softened and you're sort of breaking the first line of the skin integrity, and you're kind of leaving the skin susceptible to that that macerated tissue sort of sloughing off and leaving more open tissue underneath. So that's also a sign that we probably have too much moisture in the wound and need to do a better job of dressing selection that's going to better control that drainage. Now for the wound measurements, that's an area that can be a little tricky for people. So we wanted to spend some time today talking about that. We want to measure at least once a week in the home care setting. That's actually probably a good practice in all settings, but for sure in home care it's important. It's typical to pick the first visit of the week. That way there's no confusion. You know, you don't end up with, well, I thought Mary was doing it, or I thought Bob would do it when he was there later in the week. Instead, you end up with, if it's the first visit of the week, you're up, you're the one who's supposed to measure it. So another time that you want to measure wounds is anytime there's a change in status. So if you go there and it looks vastly different than it looked before, you know, you look at it and you say, oh, wow, that looks bigger, or that looks smaller, or whatever, then that's probably a good time to want to measure it also, just to see if in fact there has been a change in it. So one of the other things we do when we're talking about wounds in terms of measurement is we want to describe the types of tissue that we saw. And we talked a little bit about red, yellow, black. So for instance, you could say that a wound is 50% beefy red and 50% yellow slough. Now again, no one's out measuring them. You're just glancing at the hole and making a decision. You go, yeah, that looks like about half of the wound is red, the other half is yellow. And so then you want to describe that percentage in your note. As I mentioned earlier about eschar, that thick leathery look, that'll often encompass the whole wound. And it's attached to the edges of the wound. Like I said, it has a leathery sort of appearance. And so in that case, you would say 100% eschar. If it has started to tear away from the edge and you can see either some pinkish red tissue or some yellow tissue or whatever, then you might say it's 90% eschar and 10% pinkish red. But the idea is you want to try to give a description based on what you're seeing and doing it in percentages and color of tissue. Now for measuring, you want to measure length, width, and depth. Let's go to that next slide and see those full thickness ones. Let's see. Okay, this is probably a good example. The one on the left is a heel. And so you can see then how you can figure out that the top part of it, you want to measure from 12 to 6 for the length. So 12 o'clock is the head. So you're going to start at the top of that wound up more by the ankle and measure down. You want to also measure inside edge to inside edge. If you see that white ring that's around it, you want to stick your cotton tip on the inside edge of that and then bring it down and use your fingertips to mark the bottom inside edge. Often people will try to measure the white area that's around it, or they'll include some of the tissue because it's red or whatever. But in theory, you really want to measure inside edge to inside edge, and for length, you want to do 12 o'clock on the body to 6 o'clock. So 12 o'clock is the head, 6 o'clock is the feet. For width, we say that you want to go hip to hip. So again, this is a heel wound, but you would go side to side and measure your width. For the depth, you want to kind of tap around with your cotton tip until you find the deepest part. And that's the part that you want to measure. So you'll put your cotton tip in, find the deepest part, and then again, mark it at the edge of the wound with your fingertips, bring it out, and then put it on your measuring guide and figure out what the depth is. Then you want to tap around the inside edge all the way around to see if there are any tunnels or undermining. And we're not going to get real complicated today and talk a lot about that, but the basic description is a tunnel is a long skinny opening. Undermining is more like a shelf that goes underneath the wound. So you want to describe those in terms of clock also. Like if there's a tunnel, you could say there's a tunnel at 2 o'clock and it measures, so you go inside and then mark it from the outside edge and say there's a 2 centimeter tunnel at 2 o'clock. If you have undermining, you could say from 1 to 3 o'clock there is undermining and it measures 0.5 centimeters. So that's without getting too complicated, but those are the general basics of wound measuring in terms of tunneling and undermining also. Those get a little more complicated. When you do your competency, you'll get a little better opportunity, I think, to actually practice that, but those are the basics of it. So these pictures here are pictures of full thickness wounds, and it basically just means we've gone through all of the layers of the skin. This one on the right is a nice beefy red like we talked about. The one on the left is a little what we call dusky red. So that one may not be quite so healthy. It's got the white ring of macerated tissue around it. So we may want to, try to put some cleansing type product on that to clean it up a little bit and give it a better chance to heal. So again, some of the basic principles of measuring. You want to insert the cotton tip and measure wound edge to wound edge. And then for undermining and tunneling, again, you want to insert it under and then grasp it with your fingertips, pull it out and measure. Tunnel's a long, thin area. Undermining is more like a shelf. So for wound treatments, that's where it gets really tricky and people struggle a lot. So you're, again, not expected to be experts. That's what people like myself are here for. But what we do want you to do is have some idea of some wound treatments and how you pick them. So one of the first things we want to talk about is that a warm, moist environment facilitates wound healing. That's one of the reasons if you've ever heard we wound types tell someone to take the normal saline out of the refrigerator about an hour before we come. That's why, because the cold sort of scares the wound, and so it works best if it's a warm, moist environment to heal. That's another reason for a lot of the closed dressings that we don't open up for 2 or 3 days. We're trying to foster this warm, moist environment for them to heal. So some of the principles of wound healing are, I say if it's wet, you want to dry it out. So you're going to use an absorptive type product. Some examples easy for me to say, absorptive type products are calcium alginate, hydrophara blue, that's that bright blue purple one that looks like cardboard when it first comes out of the package. You can, in fact, also use Meta-Honey alginate, that will help absorb too. If it's dry, you want to add moisture with a hydrating product. And some examples of that would be like a silver gel, a hydrogel. There are moist products like Vaseline gauze, Adaptic, which is also called a contact layer dressing. So again, we don't need to get too complicated. This is a basic primer. We're just throwing some ideas out there that you can build on. The last part of those principles of wound healing are that if it's dirty, then we want to clean it up. And that's what I was talking about a little minute or so ago on the wound on the left. If the wound looks like it's not healthy, then we need to try to figure out a way to make it healthy. And that may be a time when you would see us turn to a solution called Dakins, which is also sodium hypochlorite. It's basically bleach water is what we're talking about. And it's used often to control odor if you have a very odorous wound with a lot of slough or eschar that's softening up and causing a great deal of odor. For hospice patients where healing is really not the goal, but they have a great deal of odor, then we might use Dakins on that. And then lastly, it'll clean up what we call the bioburden. And the bioburden is not necessarily an infected wound, it's really just a wound that has a lot of contaminants in it. And wounds in general, because they're open to the air, have contaminants in them. It's in the air, it's unavoidable. Foot wounds are particularly susceptible to that because they're down low to the ground, and most of us have seen the floors in many of the homes that we go to. So that's what we talk about bioburden. That's what we mean. It's not necessarily an infected wound. It's simply a wound that is maybe just not as clean as we would like it, and the tissue's not quite as healthy. So we might have to do something like a Dakins for a week or two to kind of clean it up a little bit and maybe put it in a better position to heal. So I talked about some absorptive products. We'll go over those one more time just for review. A calcium alginate, a hydrophara blue, Me-Salt also sprang to mind. Me-Salt is a fancy product that is really just gauze with normal saline baked into it, if you will, in the factory. But it is a highly absorptive product, and it does also have bacteriostatic properties. So if there is some bacteria, it can help to kind of cut back on that. Hydrophara blue will also do that. It's bacteriostatic as well. Calcium alginate, if you use it with the silver formulation, will also give you a antimicrobial property. And then finally there is Triad, which is a hydrophilic wound dressing. That's the one that comes in the big gold tube. It looks sort of pink when you put it on. That one can be used to debride. It adds moisture, but oddly enough, it can also help dry out a wound if it's too wet. So that one gets a little more confusing, but I just throw it out there because we're kind of fond of it in the home care setting and use it a lot. The hydrating products we talked about are Hydrogel and Meta-Honey Gel. There's moisture barrier ointments such as Vaseline, Aquaphor, and also A&D ointment. And then there are products like Vaseline Gauze that will add moisture to a dry wound. And then lastly, often you'll see us trying to debride a wound, and so one of the things we're fond of in home care is calcium alginate and foam for what we call autolytic debridement. That is just a way of saying that we are encouraging the body to rid itself of the dead, devitalized tissue. Hopefully the calcium alginate moistens it up a little, maybe sticks to it a little, and when you take the dressing off, that dead, devitalized tissue will come off. Santal is a prescriptive ointment that is put on a wound to try and encourage sort of the Pac-Man product. It'll kind of eat away at the dead, devitalized tissue. And then the Triad we talked about will help with debridement. It has like little debridement granules in it. So that is a quick primer on talking about like some different treatments, talking about how to measure wounds, talking about how to assess wounds. Sharon, I think we had a couple more pictures we could show them as well. So this is sort of a schematic representation of different pressure injuries, stage 1, stage 2, 3, and 4. And so one of the things that I like to point out to people to give them an idea of how you identify them is, remember, stage 1 is always intact tissue. If there's a break in the skin, it's not a stage 1. Stage 2 is probably a scratch and beyond, but you haven't gone through all the layers of tissue. If you have slough or any of that dead, devitalized tissue that I spoke of, then it's at least a stage 3. And if you can see bone or muscle in it, then it's at least then it is a stage 4. It's not at least, it is a stage 4. So those are some quick little primers. If it's intact, it's a stage 1. If there's a break in the skin, it's at least a stage 2. If there's slough present, then it's at least a stage 3. And if you can see or feel bone, it's a stage 4. So this is talking about deep tissue injury and unstageable. And basically the difference between those is deep tissue injury is going to be intact skin, but it's going to have a dark purple, almost maroon sort of color. On people of color, it will definitely be more purple looking. It doesn't blanch when you press on it and try to take the color out of it. It doesn't go away. It stays that dark, deep purple kind of maroon. It's basically telling you that something's been going on under there for a long time, and it's highly likely that that tissue will open up at some point. Unstageable is covered by like that thick, black, leathery eschar that we talked about, or it has so much dead, devitalized tissue in it that you are unable to see the base of the wound and actually know what you're dealing with. So if you can't see at least 40% of the wound, then you probably want to term it unstageable because you don't really know what's under there. And that, I tell people, think of it like a core. When all that dead, devitalized tissue comes out, you could have a really big hole under there. So that's why it's best to just call that unstageable. So that's basically the quick primer on the wounds. Do we have a few minutes then to go over the check yourself questions or no? Sure? Okay. So I came up with some questions that will help you decide if you got what you needed to get out of this and if we met the objectives. We want to talk about 3 steps in wound assessment. We talked about assessing the drainage, we talked about odor, and we talked about the color of the wound. So those are three right there when you're assessing a wound. We talked about the correct order for wound measurement. You want to go top to bottom, or 12 o'clock to 6 o'clock, head to toe for the length. Then you want to do the width, side to side or hip to hip, and then you want to do the depth. And the reason for that also is that that's a universal protocol then. I can look at any measurement and know that I'm looking at the length first, the width second, and then the depth. And then as a byline, you would make the tunneling or the undermining information part of your note. So then what you also want to do is talk about the type of tissue that you're seeing in the wound, and we talked about measuring that in terms of percentage. So for instance, if you were, can we back up to that other one? I think there was one was, yeah. So right here, for instance, on this one on the right-hand side, I would look at that and I would say that is 50% beefy red and 50% yellow slough. Because that's about 50-50 of that wound. So that's an example of how you look at a wound and identify what colors you're seeing in it. So then one of the other things we talked about was an example of a hydrating product. So we can throw some of those out, like hydrogel, Vaseline gauze, a silver gel, and then we also talked about what we call moisture barrier ointments, such as Vaseline, Aquaphor, or A&D ointment. We want to talk about two absorptive products. So if you can take a second and think about that, you'll remember that we talked about calcium alginate being a highly absorptive product, and we talked about the fancy baked on in the factory gauze with saline in it, and that is Mesol. So those are two examples. If you have a really wet wound, those are two good choices to try to dry it up. If you have a really dry wound, the ones we talked about a few moments ago, the hydrogel, the silver gel, Vaseline gauze, those types of products will add moisture to the wound. And then lastly, I wanted to see if you could name one debridement product. So I'll give you a second to think about it. So we talked about Santal, which is an enzymatic debrider, kind of like Pac-Man. You put that ointment in the wound, nickel thick, and it sort of eats away at the dead, devitalized tissue. And then we also talked about we talked about Meta-Honey can be used as a debrider. We talked about Triad as a debrider. So those are some examples of debriding type products. So in summary, we talked about the importance of assessing the wound. We talked about what are some signs where it might be infected and what are some signs when it's not infected. We talked about some products which might make you think that there's an infection because of a funny odor or a funny color. We talked about how to accurately measure a wound, and that it should be done once a week at the first visit of the week. And then we also talked about some different products, and we talked about the fact that if a wound is wet, we want to help dry it out. If it's dry, we want to add moisture. And if it has a lot of dead, devitalized tissue, then we need to debride it. And so that's some of the criteria that we use for our product selection. I hope this quick little primer was helpful for you. All of us in the WOC Mobile Wound Group are always available for questions. We're always available to take your calls. So you can jot mine down right now in case you don't have your list. 216-404-6465. Give me a call if you have questions. Thank you.
Your name?
Joni Paris. I told him at the beginning.
Perfect.
Is that okay?
Yeah, that was nice. Did you like it, Jay?
So was it pretty close